Hi everyone, my name is Adam Ho. I'm the Managing Director here at Jobskin Australia and Jobskin New Zealand. Today we're proud to introduce the one of our first webinars for 2021, Introduction to Compression. We hope you'll enjoy it, and I'll hand it over to Rosemary.
Hi everybody. If we were doing this in person, which sort of seems to be a bit of a thing of the past at the moment, I would sort of whiz around the room and ask you for your experience and exposure to compression, but because practically over Zoom it's not that easy to do that, or Teams I should say. I just apologise in advance if we're covering information that's familiar to you, but our feeling is that it's better to assume less rather than more, because we want this to be useful and comprehensive for you. So today what we're going to be covering is a basic overview of compression. So we're going to discuss the indications for the use of compression, and I know some of this information will be familiar to you, but it might also help you to consider some things that you may not have thought of previously. Then we're going to go through the aims and the mechanisms of action for compression. Most importantly, we'll cover precautions and contraindications for compression, because I think that often ends up sitting in the domain for therapists, particularly where we receive referrals that are not necessarily appropriate. We'll talk about the importance of compression being graduated, and then we're going to cover an overview of how garments are made and why you would choose one type of construction of garment over another, because that's really driven very strongly by clinical need. And then we'll finish up just by discussing a bit about the differences between custom-made and ready-to-wear garments. Veronica, who is the clinical advisor in New Zealand, my counterpart in New Zealand, will be, yep, there she is, waving down the bottom. She'll be sort of running questions like a response. So if you have something that you want to ask, it's probably easiest just with the mute and the unmute and all that, if you write something in the chat, and then Veronica can interrupt me if I'm in full flight and just say, let's go back and clarify this. So please don't hesitate to ask questions or make comments, because we certainly want this to be as useful for you as possible. All right, let's get started. Now, compression, as I'm sure you're aware in just your exposure to in clinical practice, has got a range of applications. So the origins of compression actually started with vascular indications. And just a little bit of an aside, you've probably, like, the name Jobskin actually hails sort of our heritage, comes from Jobst, which you'll also see Jobst, that name pops up in different companies in different forms. But Conrad Jobst was actually an engineer who had vascular issues himself, and he noticed that he got relief when he was in the water. So he put his engineering brain to work, and he's often spoken about as the father of compression. So really, vascular indications were the original clinical needs that were met through compression. But it's expanded far beyond that. It's used heavily, of course, in lymphedema, but also dependent edema, traumatic edema, certainly in palliative care. Jobskin is very heavily involved in compression for scar management, and it's used for both hypertrophic and keloid scarring. And if this is an area that's a bit unfamiliar to you, we have got another webinar coming up that is specifically about compression for scar management, and we do talk particularly about the differences between hypertrophic and keloid scarring. It's used for postural support and correction. That can be used in conjunction with some of the other clinical indications, but also used for people with hypermobility, Ehlers-Danlos, or anyone on the hypermobility spectrum, in fact. And it's also used similarly for sensory stimulation. So what exactly are the aims of compression? Well, I'm sure it's immediately obvious to you that with that extensive range of clinical indications. We have different aims that might be used in different contexts. So where we're talking about the edema family, compression aims to reduce the formation of excess fluid in the interstitial spaces, and we'll come back a little bit more to that, but also to increase the total pressure to encourage that reabsorption of that excess fluid and thereby reduce edema. From a vascular point of view, it reduces dilated vessels, particularly veins, and improves valve function. It enhances the effectiveness of the muscle pump. It increases the rate of fluid flow in both superficial and deep veins. It ensures, in the case of graduated compression, that the fluid flow runs distal to proximal. It causes capillaries and scars to reduce the fibroblast activity, which in turn produces increased collagen, which creates hypertrophic and keloid scars. And it provides pressure to damaged skin to facilitate reorientation of those same collagen fibres in a uniform pattern. And that final sort of clinical indication, it provides postural correction, support, and sensory stimulation. Now we're going to look at those in a little bit more detail so that you understand exactly how this works, and particularly some of the anatomical and physiological underpinnings of this. So this is kind of back to Vascular 101. In just a normal, healthy person, the valves in the veins, and if we consider the lower limbs particularly, where blood is being returned to the heart against gravity, the function of the valves is to allow single directional flow and prevent reflux of that fluid. So the illustration on the bottom left, you can see that as the blood is pumped through the valve, when it relaxes, the valves fall closed, and any function of gravity and vascular reflux means that the blood only flows back a small way to the valves where it stopped. And so then the next surge forward from the activation of the calf muscle pump moves it into the next segment, a little bit like the lock system for water flow in the UK. However, when there is vascular damage, so you can see in the right-hand illustration where either from varicosity or where the presence of thrombosis, the veins fail to close properly. Sometimes it just means that they're kind of swinging in the wind just in the middle, so that there is this constant backflow of blood through the centre of the valve. Sometimes it actually means that the valves are forced further down, and it increases that problem. So let's talk a little bit about the vascular and the lymphatic system. And those of you who work in lymphedema, this is incredibly familiar information. Those of you who perhaps work in different clinical areas may have been less exposed to this. You know, obviously when we all qualified as clinicians, we did overviews of this, but speaking for myself, until I then moved into this area, a lot of the information about the lymphatics had gone by the by. And in fact, the information that we now have access to, or the evidence suggests that these figures that are on this current slide are perhaps not as accurate as we previously thought, because for many, many years, we've worked on the assumption that 90% of the fluid that sort of diffuses out from the blood capillaries is reabsorbed into the veins and return to the heart. But current evidence actually suggests that almost all of that fluid that comes out from the capillaries is returned via the lymphatic system. It's no longer considered to be the excess 10%, and that really fluid that is returning to the heart through the veins is fluid that stayed there throughout the circulation. But regardless of the actual quantity, what's important to understand is that the lymphatics begin as blind end vessels in the tissue spaces, and these are the green vessels in these illustrations. And if you look at the bottom right illustration, you can see that that blind end lymphatic has got like little blue ties to surrounding tissue, and they're anchoring filaments that actually tug on the cells that open the spaces between the cells to allow for fluid to enter the initial lymphatics. And what I often say to patients that it's important to understand is, whereas fluid returning to the heart through the veins has still got a bit of oomph behind it because the blood has been pumped through the arteries, the lymphatics have nothing, because they start as blind end vessels for a one-way system, which a significant amount of is works against gravity. So, as I say, I apologise if we are covering things things that are very familiar to you, but when we run these workshops in person, there is usually a portion of people that go, no, please make sure you cover it, because I'm not entirely sure. So let's talk a little bit about the difference between edema and lymphedema. Essentially, when the lymphatic load exceeds the transport capacity, you get edema. So that means too much fluid, not enough ability to remove that fluid away. The most obvious example is in, say, a sprained ankle. So a lot of fluid rushes into the local area, and the perfectly able lymphatic system just can't deal with that influx. It's a little bit like a tidal wave, how that fluid just can't drain immediately away. So essentially what that is an increased amount of capillary filtrate. And I liken that to traffic flow. So peak hour, when we're all trying to get to work, there's a lot of cars on the road, and the roads just can't cope, can't keep it moving at the same rate. However, lymphedema is when there is a reduced capacity for transport, but it's a normal lymphatic load. People with lymphedema aren't producing any more fluid, or they don't have an onrush of fluid into a localized area. It's a normal amount of fluid that's circulating, but the transport system is incapacitated. So it's a little bit like, well, I'm based in Perth, and for about the last 18 months or 2 years, our freeway has been being completely overhauled, the main arterial north-south freeway, so that half of the freeway is closed most of the time. So even in the middle of the day when traffic is light, we're stuck in a traffic jam, because the actual transport way cannot cope with the number of cars. There's actually less cars than usual. That's similar to lymphedema. And then when we're discussing lymphedema, there's two main causes: primary versus secondary. Primary is something that someone essentially inherits. It's a iatrogenic form of lymphedema. People are born with some kind of deficit or dysfunction in their lymphatic system, even if it maybe doesn't manifest until they're in their 30s, 40s, 50s. Secondary lymphedema is acquired, secondary to surgery or trauma, so interruption of the lymphatic vessels. And I do notice in my own clinical practice a lot of confusion where people believe they have lymphedema, but in fact it's neither primary nor secondary. It's actually a chronic edema, and that's a little bit different, and so we manage it slightly differently. There is, of course, there's always an exception to the rule where you can have an increased lymphatic load combined with a reduced lymphatic transport capacity. You get a double whammy, and that's really classed as a mixed edema. Okay, we'll talk a little bit about the muscle pump, and you've probably all heard at some time or another that the calf muscle is described as, or termed, the second heart, because obviously, particularly for the lower limbs, it's only for the lower limbs. When I mentioned a minute ago about the lymphatics don't have any oomph behind them, and veins have very little, they really rely on the calf muscle pump to keep fluid moving, because every time the calf muscle contracts, it expands in size and it presses against the veins and the lymphatic vessels. When we apply compression, we are also that compression's external. Then there is the internal compression from the bulging calf muscle. So what compression does is it actually makes the calf muscle pump more effective. Now let's talk a bit about precautions and contraindications, because I think, as I mentioned earlier, for us as clinicians, therapists, nurse practitioners, we often find that we are fielding inappropriate referrals. And I'm going to give you an example. When I gave a talk at one of our teaching hospitals to the vascular surgeons and registrars, and I spoke about actually one of the contraindications, which is congestive cardiac failure. And at the end of my presentation, one of the registrars said to me, why can't you put compression on people with congestive cardiac failure? I do it all the time. And I have to say I felt a bit caught out, because I thought, oh, I actually think, am I missing something? Is this a bit of a trick question? Because I feel like the answer is fairly obvious. And I sort of stumbled my way through saying, well, when you compress distally, you are increasing central fluid flow, and so you actually put pressure on the heart, kidneys, and the kidneys. And he said, oh, I hadn't thought of that. But his clinical nurse specialist sort of said to him, actually, whenever you prescribe that, we always send them off to cardiology for review first. And it's not that he was ignorant or, and I'm certainly not being disrespectful to him by providing that answer, but I think sometimes it's very easy for us to focus on the clinical need and not actually assess people holistically. So the precautions that we recommend that you work under is, if there is poor cardiac function or unstable cardiac conditions, make sure that it's checked and get medical clearance before you proceed with compression. If there is arterial insufficiency, or in fact, best practice generally would recommend that anyone going into lower limb compression needs to have their ABPIs done. And if the ABPIs come back as between 0.5 and 0.8, we tread carefully. Compression's not contraindicated, but we would use a lighter compression. So generally we would say 15 to 20 millimetres of mercury. Renal insufficiency, I just spoke about the fact that distal compression also increases the load on kidneys. Extreme shape distortions of limb and deep skin folds. Now, this doesn't mean you can't use compression, but it does mean that this has to be a very important consideration in your garment prescription. Lymphorrhea, so leaky legs, we need to tread carefully and make an appropriate prescription. Severe peripheral neuropathy, because compression can do damage. Pulmonary edema, similar to kidney and heart. And skin and scar fragility, because there is a chance that will cause breakdown with the application of compression. Contraindications, CCF, as I just spoke about, and severe arterial insufficiency. If somebody has an ABPI under 0.5, then it's dangerous to apply compression. And just as a little aside, if their ABPIs are above 1.2, I would reconsider the value of compression, because there is quite likely that there's calcification in the vessels, and so compression will be far less effective. Cutaneous infections, dermatitis in acute exudative stages, and bulky dressings all really mean that compression needs to be delayed. All right, let's talk a little bit about graduated compression. I imagine that for some of you this is a familiar term, for some of you it may not be, but simply put, it is when the compression is highest at the ankle. If we're talking about the leg, the same is true for the upper limb. It's graduated, it's highest at the ankle, and it decreases as you go up the leg. This supports the vein walls and helps, in the case of the leg, the calf muscle to pump the blood back up against gravity towards the heart. And obviously we always want to support fluid flow distal to proximal. I sometimes use the example of if anyone's ever made homemade sausage rolls and you tried to squeeze sausage meat out of a sausage, you know that you're trying to push it one way, but some of it will push the other way. Whereas if you can close off the, in this case, the distal end, and push more firmly from the distal end, then you will always ensure that the fluid goes in the same direction. Now, this is where we get into the kind of technical, theoretical bit, and that is that if you were to apply a bandage, so any of you working in lymphedema or edema management, this will be very familiar to you. If you're working in scar management or perhaps even vascular, you may not have been exposed to this, or perhaps if you are just coming across this for the first time. But if I was to wrap a limb with constant tension, so not making it tighter at the distal end and looser at the proximal end, in the case of a leg, it will definitely have the highest compression at the ankle. And this is to do with the circumference of the limb. So I'm just going to move you to the next slide and give you a little bit of information about this. Some of you may have heard of Laplace's law. I naively tried to do further reading on Laplace's law and found that it extends far beyond the realm of compression and is a very, very complex law of physics. But in its simplified form and applied to compression, it really states that pressure will reduce as the radius of curvature increases. So essentially, as a limb gets bigger, if we've still got the same amount of tension, the actual pressure being applied reduces. Now, I've given an example it's sort of mathematically here, just to help you understand. So, oh, my formula seems to have just gone slightly out of alignment on the right. I apologise for that. But the 22 centimetres you can see there and the 28 centimetres, they are actually, I measured my ankle and I measured my calf. My ankle is 22 centimetres around. My calf is 28 centimetres around. Now, I've used a fictional figure of 600. So imagine that the tension being applied is 600. If I divide 600 by 22, I get 27.7. So if we're considering that as millimetres of mercury, at my ankle where the circumference is narrower, the pressure is nearly 28 millimetres of mercury. That same pressure of 600 applied where it's 28 centimetres. Oh my goodness, my formulas, I've got a typo here. I've just realised that.
It's 21.4.
It is 21.4. I migrated this from another PowerPoint, and I've obviously had a slight lapse of concentration when I did that. But 600 divided by 28 is, as Veronica says, is 21.4. So immediately that becomes obvious that bigger circumference, less compression. Now, if I use the example of tubigrip, most of you would be familiar with tubigrip or any kind of tubular bandage. If you think about a straight strip of tubigrip with a certain amount of stretch, when you put that on a lower limb, it's going to be loose and possibly baggy around the ankle and tight around the calf because it doesn't have that capacity to change. And so that is actually the reverse of graduated compression, because we're putting more compression around the calf or possibly the thigh. And if anything, we get that squeezing out the sausage meat from a sausage example because some of the fluid is going to be pushed distally. Hence the importance of graduated compression. And that's just, I want to talk a little bit about compression classes, because depending on where a garment is manufactured, it's labelled differently. For a Jobskin garment, it will always be labelled or identified as 25 millimetres of mercury or 30 millimetres of mercury. But European manufactured garments are usually referred to as class 1, 2 or 3. And essentially Class 1 is 15 to 20, Class 2 is 20 to 30, Class 3 is 30 to 40 or above 30. But what you do need to understand is that French, German and European standards differ. We actually don't have an Australian standard. But so when you look at the origin of a garment, some might say 23 to 32 millimetres of mercury, some might say 32 to 45, whereas someone who classes, a manufacturer that classes as 20 to 30 and 30 plus, Class 1, Class 2 and Class 3 might actually be referring to the same garments. So the most accurate way to describe compression is to use millimetres of mercury. And differing clinical indications require different levels of compression. So, and how much compression and when? 15 to 20 millimetres of mercury is like the equivalent of a travel sock. A TED stocking is actually 14 to 17 millimetres of mercury. And TED stockings, just as a little aside, are really only designed for short-term use. They perish quickly. And I often see people in clinical practice that have been wearing the same pair of TED stockings for a year because they were put on them in hospital. They thought they were still doing the job. That's not so. But 15 to 20 is, TEDs are around that area, but then travel socks or light compression, that's suitable for tired, aching legs, minor leg edema, minor varicosis and mild varicosis during pregnancy. 20 to 30 is kind of the linchpin of compression and most commonly used. It's used for scar management, tired, aching legs, moderate to severe varicosis, post-sclerotherapy, moderate edema, and it's also used to prevent recurrent ulceration. 30 to 40 is used for severe varicose veins, lymphatic edema, and actually what we haven't included in this slide is above that, because a number of compression garments, not ready to wears but custom, can go up as high as 70 millimetres of mercury. And just as a little aside here, I would say the principle about increasing compression, the safest way to do it is if a previous level of compression is failing, then you move up a class of compression, because it's very rare that you would look at a leg and go, bad edema there, I think we'll go straight for 70 millimetres of mercury, because that is a lot of compression. It's difficult to don and comes with risks. So we work progressively up the chain. 30 to 40 is also used after sclerotherapy. It's used for the treatment of venous ulcers and used for moderate to severe edema, and as I say, higher classes as well. Now, let's talk a bit about compression garment construction, and this may well be, if you haven't been exposed to this before, this may be something that you have never considered or, not actually realised. You might have heard people talk about flat neck garments and just think, I don't even know what they're talking about. So there's three main types of compression garments, and the difference between them is the way that they're constructed. Circular knits on the left are the majority, not all, but the majority of ready-to-wear garments. TED stockings are circular knit. Travel socks are circular knit. All the relief stockings, all those, the ones that people get from a range of different suppliers, they are circular knit stockings. And there's a couple of things that you need to be familiar about with circular knit, because you may choose to prescribe or actively choose to avoid circular knit stockings because of their construction. The reason there's a little French knitting spool as an illustration there is, I imagine that most of you at some stage will have had someone in the school playground when you were at primary school perhaps who did French knitting. And French knitting involves one single thread, and it is wrapped around those nails on the top of the spool that you can see there. And if you pull the thread tight, you get a skinny tube that comes out the bottom that's knitted. If you have it loose, it's wider. And that's basically how a circular knit stocking is made. It's one yarn that is on a giant and technically very complex French knitting machine. But because it's one yarn just knitted around continuously, if you were to cut a stocking across there, it would immediately curl because that yarn retracts. And the implication for that on prescription is that a circular knit garment just loves to settle into creases. So where you have limb shape distortions, or like a marked anterior ankle crease, or folds of tissue like lobes of tissue that overhang an ankle particularly, or knees, there's a range of trouble spots, that garment's just going to want to settle into those creases and cause a tourniquet. So that's an important consideration for prescription. The other things, of course, to bear in mind with circular knits is that they are ready-to-wear garments, so you can't modify them in any way. You can't alter the length. And what I would normally say to therapists if they're kind of new to garment prescription is, when you are measuring for a circular knit or a ready-to-wear garment, if somebody doesn't fit, they don't fit. So it's not like going and buying a pair of jeans and you're a bit wider on your hips and narrower on your waist. Let's say a 10 on your waist and a 14 on your hips, and you go, oh, I'll wear a 12, I can squeeze my hips into that and it can be a little bit loose, I can adjust it with a belt. We can't do that with ready-to-wear garments because that actually changes the ratio for graduated compression and you can end up pushing fluid distally. So if they don't fit, they don't fit. It just means that custom made then becomes a more important consideration. So the next type of garment is a flat neck garment. And this is a custom, or it can be ready to wear as well, but it's often a custom knitted garment. So the garment is made as a single knitted piece. So it's knitted to a certain size and shape, and then it has most commonly a single seam down the back. The measuring system for flat neck garments is quite different. If you have never measured for a flat neck garment before, you need to be trained specifically by a clinical rep of a flat net manufacturer. You can't superimpose another one because we actually use a combination of body measures, maximum tension, and then we often order somewhere in between. So that's based on clinical judgment. The advantage of a flat neck garment, or how it can influence your garment prescription, is that it is a much stiffer fabric. So it has the ability to ride over the curves or the creases where you have a more lobular shape. There are some options that are available, but they are quite limited in order for the garment to achieve what it needs to achieve. So then the third option is a cut and sew garment, and this is where a Jobskin garment generally fits. We do have ready to wear gloves, but the majority of Jobskin garments are what we call cut and sew. This is like, say, the blouse that I'm wearing, there was a pattern cut out based on certain measurements, and it was cut into pieces and sewn together. Same is true for Jobskin garment, although the pattern design is complex because it has to fit accurately and because it uses a multi-directional power net material. The measurements are very comprehensive, but we have a very simple measuring system using disposable paper tapes, which are awesome for infection control, but also it means the measurements are taken at very specific landmarks, or not landmarks, spaces along a limb or the body, and it requires far less of you in terms of trying to work out whether you are measuring in the right place. There is an incredible range of options and modifications so that you can address donning and doffing issues, skin fragility issues, edema, odd shapes and sizes, weird tissue distribution, a whole range of things. Plus there's a range of colours which makes it great for compliance. And the aim is to get an accurate body fit. If you have an extremely lobular limb, you can still use a Jobskin garment, but there needs to be some padding underneath, which Jobskin can also provide for you. So that's one of the beauties, that it has so many ranges of, so many options and modifications. Right, we'll talk a little bit about custom made versus ready to wear. As I've alluded to already, custom made is essential when a patient doesn't fit ready to wear garments, and that not fitting might be because of the circumference, their height, their limb length, or their proportion. If a patient's an odd shape, if you need an accurate fit or compression, for example, if we consider scar management, if somebody had scar management under the sort of, let's say, the bottom half of their breasts, they need something that is going to fit their breasts very accurately, whereas a ready-to-wear vest, of which, you know, like the post-surgical ones, will provide compression, but you just can't get the compression where you want it. So when you want to target specific areas, then custom made is a much better option. You often need to go to high, well, you definitely have to go to custom made, either flat knit or cut and sew, when higher levels of compression are required, because ready to wears are only available up to 30 to 40 millimeters of mercury. When a suitable style is not available, generally ready to wear garments are socks or stockings, some tights, and arm sleeves. But oftentimes when you need things that are for necks, you can get head and neck ones, but their fit has limited suitability. Torsos generally do far better in custom made, and same is true for actually for full length lower limbs, as opposed to, you know, below knee. And when you need particular design options and modifications, lower necklines, higher necklines, raised turtlenecks, variable lengths on arm sleeves or socks, all those sorts of things. So just quickly, as I mentioned, Jobskin do have ready-to-wear gloves, which provide therapeutic compression, and they provide a light functional support. They are made from PowerNet, so they are more lightweight, but they are durable. I know some clinicians use them as interim care garments while patients are waiting for custom-made ones, but they are a cost-effective alternative to custom-made. They don't have a thenar eminence built in or sewn into them, so they can be used left or right, and they have a very easy measuring system. The remainder of our Jobskin products, as I say, are custom-made. If you go to the, I think it's on the next slide. Oh, no, not quite. That's a little bit about the measuring system. Some of the advantages of the custom made is that they can be fabricated for literally anywhere on the body, and we can vary the weight and the type of the fabric. We do encourage you to consult us for troubleshooting. That's Veronica and myself, but also the design team are an absolutely awesome resource. I was speaking to one of the designers this morning about how we could change a vest for somebody with breast edema, and they are so good at troubleshooting and lateral thinking. I can't commend them enough for you. And I did start to mention this before, but the fact that there are so many options and modifications really allows for accurate fit for different shapes and sizes, easier donning and removal of the garments. We can accommodate a range of patient preferences. Because I'm a West Australian, I'm a keen Dockers supporter, Fremantle Dockers. For those of you from Rugby Territory, you might wonder what I'm talking about, but our colours are purple and white, so I often make a bit of an offhand joke about, you know, these garments look really good in purple with white stitching, and I had one young man who had to wear a knee-high sock, and I made my usual joke, and he said, "Oh, can I really do that? Would they stitch 3 white V's on," which kind of matches the logo? I said, "Well, give it a go," and the designers were very happy to accommodate that. And his compliance was flawless because he was so proud to be wearing that sock. And really, for us as clinicians, that's what we want, isn't it? We want, doesn't matter how good a garment is, if people are not willing to comply with it, it's of no benefit at all. So, as I say, there's a range of colour and style choices. We can vary the levels of compression, and that includes within a garment. We can have one leg at one level of compression, another leg at a different level of compression. We can target the compression. We can include linings to protect fragile skin. We can accommodate silicone products or dressings. And in fact, we now offer a silicone lining, which is only 0.5 millimetre thick, which can be stitched into the garment, which helps compliance with silicone enormously. It's very, it requires basically no effort on the patient's part. And as I say, it helps us with compliance. So how does it actually work? How do we use Jobskin garments? Well, therapists and clinicians are trained in our garment measuring and prescription. Travel restrictions have put a little bit of limitation on that, but if you have a look on the website, we have what we consider to be an awesome range of videos that actually walk you through every single step. And Veronica and I are only too happy to Zoom, Teams, Skype, whatever with you, and it can be with a patient present so that we can help you through the measuring process as you grow in confidence. We take our measurements using a patented measuring system of paper tapes and tape measures, which make it very simple to do. I can't tell you how many times patients go, "Oh my goodness, that's just such an awesome system," because it's great for them too. The measurements are then transferred from the tape onto the relevant form. You submit your order with the diagnosis, any patient problems, any specific needs you're trying to address, patient preferences, and any designer or clinical advisor input. Of course, we provide quotes where you require quotes in order to progress the garment, and then, you know, whatever your hospital or clinical system is, we can work with you for that. So when you order a garment, you need to submit a order form which has got the delivery, patient, delivery and payment details, plus the relevant measuring form. And if you go to the website, you will see all of our forms there. So if you're measuring for an arm, you go to the arm sleeve. If you're measuring for a glove, you go to the glove form. So it's a very specific form, which makes it easier for you to discriminate what you need. And then the garments are submitted, the order is submitted to that email address you see on the screen, customer.service@jobskin.com. And the phone contact number for customer service is 0399158000. Veronica, what's the phone number for New Zealand therapists? I've realised that's not on the screen either.
Please hang on a moment. I'll have to have a look.
Veronica will come back to this that for us. Oh, and in fact, yeah. So I would encourage you to go and have a little browse on the Jobskin website, and if you look under the support and training tab, you will see all the events listed for the upcoming webinars. But also you'll find the how-to measuring videos, and there's also a range of resources, documents, printables that are all available to you. Veronica and I are here to help. Our phone numbers are there on the screen. Veronica's based in New Zealand, I'm based in Australia. And as I said before, the design team are an awesome resource and they are only too happy to help. You'll find they become your next best friend as you're working with them. So let's finish with any questions. I'm not sure, Veronica, if you've received any via chat. If not, by all means, unmute yourself and ask a question, because I'm sure we can all learn from everyone else's questions. And I would just say there's no such thing as a dumb question. All right?
On the off chance that we have a New Zealand clinician on, which it doesn't look like it, but the phone number for New Zealand is 0800 765 627.
Great. Thanks, Veronica. In the absence of any questions, or if you're just trying to think of what to formulate what you want to ask, I would encourage you to consider the next couple of webinars. because the upcoming ones, we've got compression for scar management, but probably most significantly, we've got the compression prescription and design. What we've done today is it's a basic overview of compression, the principles of compression. In the garment prescription and design, we are really aiming to equip you with kind of, I suppose, a lot of the troubleshooting functions. You know, how do you get good compression just at the top of the décolletage? Or what do you do when somebody has is asymmetrical on their shoulders? How do you adjust? All those sorts of things so that you can really be very confident in what you are wanting to prescribe. We're also in that particular webinar. Is that the next webinar, Adam? Yeah.
Yeah.
Yeah, it's the next webinar. We have allocated a longer time so that we encourage you to come to that with questions or even cases that you're just going like, whoa, I had this patient who I just could not work out how to, they clearly need compression, I just don't know how to do it. As an example, I saw a young woman last week with a therapist who's had this hideously awful accident where she's lost all her abdominals and she has got only skin covering over her organs, and she's a young woman. She's also had spinal fractures. She absolutely needs compression to be able to get up and around, but how do you do that in a way that's safe and protective is one of those clinical challenges. And as I say, that's what Veronica and I are here for, to help you work those out. But that's the sort of one that would be a great one to discuss in our prescription and design workshop.
Probably I would just like to jump in and say, so when you get to the point where you're thinking to yourself, I'd really like to have a go, as Rosa said, we are really available and more than happy to have a bit of a practice run with you over Skype, Zoom video before your patient walks in the door. And in order to get hold of like the tapes and stuff, you can find a ordering method on our website. So our website has got not only the training tips and tricks videos, but there's heaps of resources on there. You'll find information around, you know, if you're struggling with a little bit of a fit issue, what some of the ideas are around that. You'll be able to download all the different options and modifications for possible custom garments to help ensure fit or engagement in treatment. So, you know, I can't emphasize enough that the website is an amazing resource, and you know, you can look to order a pack of trial tapes so that you can have a bit of a play and a bit of a go before the patient walks through the door.
Well, I think in the absence of any questions, either we have completely bamboozled you, or I'm going to be optimistic and hope that we've provided useful information for you that hasn't left you with questions. But as I say, we'd love to have you back on our subsequent webinars, and do check out the support and training tab, which does outline all of the ones we've got coming up. There's a huge range of them actually, and I actually think there's a few exciting ones coming up because we've got some quite complex ones in there that are really stimulating. So,
Miss Ellen says, I have a question.
Oh, okay.
Go, Ellen. What's your question? She's typing. Megan said it was great. Thank you.
Ellen's still typing.
Megan has just asked, will this be available to watch again later?
Yes, it will. Yep. And Ellen's question is, can you describe the most extreme case of compression and how you treated it? Actually, I've got a really good example for this that is I think is really interesting, because I had a man in his late 30s who I went to help somebody. They asked me to come and help measure them. And when this gentleman, very fit looking gentleman, when he came into the room, he took off his trousers, and then he took off his compression stockings, and then he took off his second pair of compression stockings, and then he took off his third pair of compression stockings, and finally he took off his fourth pair. So he had had an inguinal node resection when he was a late teenager for a malignant growth in around that area, and he had lymphedema of his upper thigh. Now, he was, as I say, he was a very fit bloke. He was cycling a lot, so he was very muscular, but the upper thigh would fill over the day, and he could not control it. So he had resorted to wearing 4 compression stockings in one hit, which was just completely laborious. And you can imagine in West Australian weather, where it's very hot, he was coping with this in summer. So what we did was we actually put him into a pair of tights that was 70 millimeters of mercury. But before we actually made the garment, when I was thinking about graduated compression, when it's 70 millimeters of mercury, it's 70 millimeters of mercury at the ankle. And by the knee, it's usually between a 40 to 70%. It's down to 40 to 70% of that. So let's say it's 70%, or no, it was 49 millimeters of mercury. Then by the thigh, it's 20 to 50%. So the worst case scenario is actually the compression at the thigh level is 14 millimeters of mercury, which actually is not, he was not getting compression where he needed it. So the designer that I was working with was absolutely fabulous, and we played around with how we could minimize the reduction of the graduation, but still enable that graduation to occur. So he ended up having 100% compression at the ankle, 70% at the knee, and 50% at the upper thigh, which in fact I think we went slightly higher than 50%, and that enabled him to control that edema with just a single garment. So really, that really did change his life. All right. Just seen that there's a whole lot of activity in the chat. I'm not quite sure what's happening, but we seem to have had a little bit of a technical issue. And so, Ellen, that's one example for you. I got plenty on my fingertips, but hopefully that was just enough to tantalise people. We've got our second session of this webinar happening in about 5 minutes. So thank you everyone for being here. If you've just logged on, you've logged on to the 11 a.m. or WA time 11 a.m. so depending on where you are, but session number 1. So you might need to log off and log on to the second session webinar. But thank you everyone for being here. We hope that was interesting and useful, and we hope we see you again. Bye then.
Thank you. Bye.